yet the codes still reflected that. So the new codes, what they are designed to do is to give credit to the services that you are providing. So what changed in January of 2027? Before January, as we just talked about, there was the full global package. So the codes for global vaginal delivery, global cesarean delivery, global AP codes, and global postpartum codes. Effective January 1, everything will be service-based. Antepartum care will be billed per encounter using E&M codes. Labor management has their own code set. Vaginal delivery has its own code set, as do C-sections and postpartum care. And postpartum care goes back to E&M codes. So by going to per encounter billing, multiple providers can bill for the entire episode of pregnancy, and complexity in care is recognized. We are going to spend quite a bit of time talking about prenatal visits in this particular presentation. We'll do another webinar later on labor management and another webinar on labor management and delivery and another one on postpartum care. But for tonight, we're going to talk about prenatal visits with the E&M changes because these affect you right now. So effective January 1st, E&M coding is going to be based on either medical decision-making or time. I can tell you from looking at the payer guidelines that have already been released that the primary focus for E&M coding and deciding your codes will be medical decision-making and not time. And the reason for this is that AMA and ACOG have stated that pregnancy is a complexity in medical decision-making. AMA says that you will be able to record your prenatal visits with the E&M codes, the hospital inpatient and observation codes, and specific telemedicine codes. I disagree with the telemedicine codes because none of the payers recognize them now for E&M codes for like routine office visits, preventive medicine, any of that. So they're not going to recognize them for maternity care. If you're doing telehealth, it's still a straight E&M code. And then there's the home visit codes and the critical care codes. So let's spend some time talking about medical decision-making because that is where it is going to be the most heavily weighted. So straightforward medical decision-making means very minimal. That would be a confirmation of pregnancy visit and not a maternity visit or a prenatal visit. And that is because pregnancy is classified as a condition, which automatically moves you to low or moderate. And as we go through this, you will see that pregnancy being classified as a condition moves you into the moderate E&M level. It moves you to a 99214. So because of this, in your medical decision-making, as we talked about, low MDM requires low complexity across 3 elements. Moderate is the key level for most prenatal visits. So moderate diagnosis, moderate data, moderate risk. High is appropriate for complex pregnancies with conditions that threaten life or bodily function. And as a reminder, in medical decision-making, only 2 of the 3 MDM elements need to be met or need to meet a level to report that level's code. So for example, if you meet two moderate complexities, you can report a 99214. You don't have to meet diagnosis, data, and risk. So let's talk about the problems that are addressed when we're looking at or medical decision making. Minimal is one minor problem. So again, a confirmation of pregnancy, you're doing a urine dip, that's a 99212. Low is two minor problems, a chronic stable problem, and an acute uncomplicated problem. So that would be a 99213. Moderate is exacerbated chronic or two chronic that are stable, uncertain prognosis, or an acute complicated. That would bring you to a 99214. And then high is severely exacerbated, or the condition poses threat to life or bodily function. And that would bring you to a 99215. A routine, uncomplicated single pregnancy could be minimal or low, but as we'll talk about when we go into more in a couple of slides, we'll talk about charting the visit and assigning an ICD-10 code. You will want to look at other things. So everybody's used to coding routine maternity care right now with a Z34 code for routine pregnancy, and then a Z3A code for gestational weeks. But as we look at medical decision making, you'll want to change your thinking to, is there anemia? Is there gestational diabetes? Are you managing thyroid medication? Are you managing obesity? Other conditions that could potentially be affecting the pregnancy.
Arden, can I ask a question?
Mm-hmm.
In sitting in the meetings, they talked about social determinants of health as indicators. Is that
We're going to get to that.
okay?
Social determinants of health are no longer an indicator in the way they talked about them in the meeting. In the meeting, it was talked about for more in the delivery or in the labor management. That was taken out. But now social determinants of health can be a complexity in the prenatal visit if it is directly affecting that visit on that day. So if it's adding complexity to the visit on that day. And then data also comes into your medical decision making. So for minimal, did you order any tests? Did you review any documents? Are you reviewing any orders? Low, did you do 2 tests? Are there more documents? Or are you relying on an independent historian? Moderate, are you reviewing 3 tests? And it doesn't have to be 3 tests. It could be 3 tests, documents, orders, or historian. Are you interpreting any tests, or are you having a discussion with another midwife or with a physician regarding the care? And then extensive is test interpretation, discussion with others also, but at a higher level. And then there's risk. Risk is the third and often the most powerful in medical decision making. For prenatal visits, prescription drug management alone supports moderate risk. Managing gestational hypertension with medicine, counseling about social determinants of health, or planning for a procedure all support moderate risk. So a 99214. High risk applies when the patient's condition poses a threat to life or bodily function. So one element at a given level is sufficient in the risk category to anchor the MDM at that level if two of the other three helped you reach it. So, for example, diagnosis, problems addressed is one. If those were moderate, but the amount and complexity of data that you reviewed was not, but there is a risk in the social determinant of health that brings you to a 99214. And I have a little chart for you, and I have a handout that I can have Ginger send to the listserv because I know this is a whole lot of information.
Hi,
So
Arden.
then,
Quick question. So let's say you have a pregnant woman come in, and let's say you do some testing, and then you think, okay, I want her to go to triage because I'm concerned about, I don't know, the baby's not moving as much, or we maybe have non-reactive non-stress test, or your BPP is not great or something. So you send the baby and the mom to triage. At that point, does this mean it's a 99215 visit because it ended in a potential hospitalization, or does triage visit not qualify? And conversely, let's say you had somebody come in, you examined them and said, oh, yeah, I think you broke your water, and you admitted them for labor. Does that mean that that's a 99215 visit? Thank you so much.
so if somebody's coming in and you assess that they're a high level of risk and you're sending them to triage, that's obviously a high level of risk. So that would qualify a 99215. If someone comes in and their water broke or you think they're in labor and you're sending them for an admission, that is a 99215. And then that will carry over into the labor management or hospital admission, which we will get to a few slides from now. And then there's coding based on time. So I'm going to briefly touch on this because most of the payers are going to want you to code based on medical decision making for pregnancy. No one's saying you can't code based on time. However, your documentation, if your visit is time-based, needs to be extremely clear as to how much time you spent with the patient, direct face-to-face time with the patient, how much time you spent with a family member or a caregiver, or even the patient again, providing history, care planning, how much time you spent ordering tests, reviewing results, reading the records, and how much time you spent on care coordination with other providers and other staff members. And if you're coding based on time and you are always reporting a 99215, for example, because your time is 40 minutes or greater, your your claims are going to be flagged and your biller is going to have to provide charts for every single one of those claims to substantiate the use of the 99215. And that is why it is safer to code based on medical decision making. And this is just a reminder of what total time is. For new patients, it's different than established patients. New patients, 15 minutes is a 202, 30 and 99203, 45 a 99204, and 60 minutes is a 99205. Where with an established patient, it's actually less time to get to a higher level. So 10 minutes for a 212, 20 minutes for a 213, 30 for a 214, or 40 for a 215. And total time includes, again, both face-to-face and non-face-to-face work on the date of the encounter. It does not include any time that you spent the day before, the day after, or when you chart later. It's only on the day of the encounter. And the time thresholds are minimums. You have to meet or exceed the minimum time to report that level. I will tell you, with the use of AI and all of the various coding software, diagnosis codes factor into your time spent, because your biller, if your diagnosis code does not support a higher level of medical decision-making or time, it will hit an edit before the claim ever goes out the door, and it will be flagged for your biller, who will then come back to you or review your chart. And then all maternity visits will be used. ACOG recommends the use of a TH modifier on all maternity visits. I recommend you start using the TH modifier now to show that it's a maternity visit. The payers are supposed to start implementing it before September 1st, but at minimum, they are being told to implement it on September 1st so that they are ready for January 1st. The TH modifier signals the payer that the service is part of maternity care, and it distinguishes OB visits from general medical services that use the same CPT codes. So it distinguishes from a maternity visit with a 99214 versus a well person or a sick visit, I should say, with a 99214. You will apply the TH modifier to all prenatal visits billed with an E&M code, all postpartum visits billed with an E&M code. The AMA says to all telehealth visits, those will also need a modifier 95, so it'll be a double modifier on those visits. So now let's talk about how we document all of this so that you're meeting your medical decision making or your time. Because I preach this a lot. If you don't chart it or if you don't document it, it did not happen. Documentation is key. It is the key to medical decision making, and it is the key to coding based on time. We are all familiar with the prenatal flow and charting using a prenatal flow sheet. And the prenatal flow sheet is great. It serves its purpose. I'm not saying we throw the prenatal flow sheet out with the bathwater, but we do need to start charting with SOAP notes. Because now that maternity care is being reported per visit, you have to be able to document all of the conditions that you evaluated, monitored, assessed, treated, or otherwise addressed during that specific visit. It's not, you're not coding based on history of anemia, history of obesity, history of heart disease, history of whatever. History of will not factor in. It's only the conditions that are evaluated, monitored, assessed, treated, and addressed during that specific visit. So some conditions to actively document are anemia complicating pregnancy, obesity complicating pregnancy, hypertension, gestational diabetes, or other maternal conditions requiring ongoing assessment or management. The diagnosis code that you use must reflect the patient's current clinical status on that day. Any medical necessity of services provided at that encounter, specificity, I can never say that word, of pregnancy-related conditions and complications, and any risk factors actively addressed during prenatal delivery and the postpartum period. And this again is where the social determinants of health come in as a risk factor. And this is why I talked about before the Z34 code that everybody was used to will not be as important. Because with the implementation of the 2027 maternity coding changes, you will no longer be able to rely primarily on routine supervision of normal pregnancy with a Z34 code. Coding will now require greater specificity. Coding will require regarding your pregnancy-related conditions, complications, and risk factors that are actively addressed throughout the prenatal, delivery, and postpartum periods. You will be coding based on medical necessity, so accurate documentation and diagnosis selection is essential to support medical necessity for every service billed. Appropriate reimbursement will depend on your diagnosis coding that ensures that complexity and risk are recognized and appropriately reimbursed under the new framework. And payer compliance, payers are going to require that you are charting with a SOAP note instead of a prenatal flow, and that you are coding based on the new framework by documenting all conditions being actively managed. So accurate documentation plus specific diagnosis coding equals medical necessity and compliant reimbursement. So what do you do right now so that you structure yourself to be ready January 1st? So anyone who is currently pregnant and they had their first visit before May 15th, or they will deliver in 2026, is billed globally. They're billed with the old codes, whether it's 59400 for global vaginal, 59510 for global C-section, or if they were late to care, insurance changed, you'll use the global antepartum code and then the delivery code. Phase 2, that's the gray area, even though it's orange on my slide, because their visit between May 15th and July 14th, they should deliver in 2027. Some might deliver in late December. And here the payers may request 59426 for global prenatal care, plus the delivery only code in December, starting as soon as December. Or they'll request the old codes for 2027 and the new codes for January. And we'll know more about the payer guidelines later in the year. Some have started releasing them now, but they will definitely release them in September, October, November. Phase 3 is anyone whose first prenatal visit is between July 15th and August 31st. As of today, most of the payers will require that you use 59425 for 4 to 6 antepartum visits in 2026. And then you use E&M codes and the new delivery codes for 2027. And then phase 4 is anyone who is pregnant from September 1st onward. It's all the new codes. You're billing per visit for the rest of the year, and then you'll bill the new codes in January. The biggest change in all of this is labor management. This is where the most codes were added, and this is a huge win for everyone, is labor management. I'm going to touch on it briefly tonight, and we will talk more about it at a later date when I've been trained more on it. I will come back and train you all more on labor management and delivery. Labor management is now separately reportable with its own code family. 59080 is initial day labor management. This is for straightforward labor management on day 1. 59081 is for complex labor management on day 1. And then 082 is subsequent straightforward, and 083 is subsequent complex. So what makes labor management straightforward and what makes it complex? When we were first discussing these codes last year, there were members of the group who wanted to make social determinants of health a complexity. As you can see, that's no longer there. It was removed. Straightforward labor management has to meet all of the following criteria. It cannot meet one, it has to meet all. So straightforward labor management is singleton vertex presentation, routine maternal fetal monitoring, no physician intervention for fetal monitoring, normal labor progression or routine induction, stable comorbidities with no additional management, and no VBAC, no previous cesarean delivery. That is straightforward labor management. If they do not meet all of those criteria, it becomes complex. Complex labor management is if any of the straightforward criteria are not met. So multiple gestations, twins, always complex. Previous cesarean, fetal distress requiring intervention, labor dystocia or arrest of labor, active hemorrhage, HTN crisis, or eclampsia, all are complex. And if someone starts out as straightforward and develops a complexity during that calendar day period, you report the complexity code. And it will be very, very important that you document all of the straightforward criteria. And if it moves to complexity, that you document what was complex, what moved it to complex. Because wearing my biller hat right now, the payers are going to require chart notes. They're going to request them.
Good question. When you say that it's day one versus subsequent day, does it count like hospital admissions from midnight, like before midnight, after midnight, or is it from the time patient is admitted and then 24 hours added on? So let's say I have a labor patient coming in at 10 p.m. And let's say they deliver the next morning at 2 o'clock in the morning. Does it mean they were in labor for 4 hours, but I'm like a girl and I get to bill 2 days? Or does that mean that, sorry, girl, you're 4 hours and that's that?
As of today, and this is subject to change because they haven't released this is the only definitions that are released as of today, but as of today, it's per calendar day. So if they're admitted before midnight, that's day one, and then day two is after.
Okay, like yes.
So, and here again, initial day, report initial day, first calendar date induction begins or labor management starts. The same physician or group has not previously provided labor management for this admission. So if Katya, if you admit the patient and it's calendar day one, and you're the only person who has done labor management in your group, then you report the initial day. If Katya and Shelley are in a practice together and Katya admits and she does labor management on day one and Shelley does labor management on day two, Katya reports initial day, bills initial day, Shelley bills day two for subsequent day. If you're in two different groups, Katya reports initial day one, Shelley reports initial day one on day two, because she's in a different group or a different NPI tax ID number.
Can I ask a logistics question on that?
Sure.
I know you didn't really want to get into labor and all that, but so you said if provider one is on day one and provider two is on day two, you each bill separately for that. But like, what about, for example, tonight I am on overnight, and so if I had somebody here in labor right now, like, or let's say after midnight, I admitted somebody in labor, but I leave at 7 in the morning, and let's say they birth at noon. That's two different providers, but the same calendar day. How does that work?
If you're in the same group, then that is up to your hospital system, your biller, your practice to decide who bills. If you're in two different groups, two different MPI numbers, tax ID numbers, then you each bill.
Thank you.
You're welcome.
Uh-huh.
And then if a different specialty assumes care, so Katya admits she does labor management for half the day. She determines that this patient needs escalated to MFM. Katya bills for initial day for the time or for the day she spent, and MFM, they will also be able to bill for initial day of labor management. The difference is Katya could potentially, actually no, because she's escalating to MFM. So neither one would be straightforward. They would both be complex.
On a
And then
related note, and this is not relevant to the group, just tell me and we'll discuss it later. But for those of us who are working in a situation where we have collaborative physicians, so for those of us who are working in autonomous practice states or similar setup, where the hospital requires for us to collaborate with a collaborative physician for every birth, where they're required to be, let's say, in my case, in the hospital, when my patient is in active labor and actively pushing, I must have my collaborative physician physically in the hospital. Do they get to bill for their thing and I get to bill for my thing? Or, and if you don't know, that's completely fine.
I don't know yet. Stay tuned.
Okay.
That will come later. And then from the webinar I attended with ACOG and their town hall, you would both be able to bill. However, I'm going to defer that further explanation until after the AMA webinar because they make the final rule.
That would be really great if that were the case, because right now I have to pay out of pocket for that. And if insurance would pay for that, that would be a really helpful thing to me personally, and possibly to some other people who are, let's say, midwives who are with collaborative situations.
That would be great. Yes. And then some key rules in reporting labor management. It requires face-to-face. You can't manage labor from the call room, from your home. You have to be face-to-face. Not the whole time, but you do have to actually see the patient. I say that because I reviewed chart notes for somebody who managed labor from their home, and I'm still trying to figure that out. Labor management is reported once per calendar date. Multiple visits on the same day equal a single management service unless it's a different specialty or a different tax ID. Continuous care spanning midnight equals a single code on one date, which I need clarification on that because first calendar date is supposed to be up to midnight, second calendar date, day 2. But I took this directly from ACOG and AMA. And then the covering physician uses the same code as the primary physician. The delivery care codes for 2027 are also changing, as we all know. Vaginal delivery will be reported with a 59431, VBAC 59432. Included in the delivery code are first and second degree repair and episiotomy and the placenta. If the placenta is delivered at the same time as the baby. If the baby comes and you deliver the baby is spontaneous, baby's born in the car on the way there, you deliver the placenta later, then there is a separate code for placenta delivery only. There's a code for third and fourth degree laceration repair, and a code for first and second degree repair if it's done by an unrelated physician. And physician in AMA and ACOG definition is any qualified healthcare provider. Cesarean deliveries have their own codes, 59502 if it's the first cesarean for that patient, 503 if it's a repeat, and a new code that the OBs are all happy about is 59504, hysterectomy after cesarean. It's its own standalone code. It's no longer an add-on or a modified code. Included in repeat cesarean are the admission and the intake work. You cannot bill inpatient E&M separately on the same day as a repeat C-section. If it's a primary section, you can bill inpatient E&M. And then postpartum care, all of the previous postpartum codes were deleted. They are no longer effective in 2027. Routine postpartum care on the same day as delivery is included in the delivery code. And then the inpatient postpartum days after delivery are reported with the appropriate subsequent hospital E&M codes. And then the discharge day is a discharge code. And any outpatient postpartum care is reported with E&M codes. A new postpartum procedure code for 2027 is 59623 for a uterine tamponade. So balloon, catheter, vacuum, packing material. So guidance for CNMs, I use CNM to cover CNM, CPM, CM, because CNMs are the recognized payable credential by CMS. Not that I agree with that. It's just how it is as of today. So these are it's a nice little chart for you to have all included in a handout for you. But as a refresher, antepartum visits, report each visit separately using the E&M codes, select the code based on the location, so office, telehealth, etc. Use MDM or time and document your complexity. Use modifier TH for pregnancy-related visits, and no pre-auth should be required. Labor management, you report the same as physicians. If you transfer care to a physician in a different group due to escalation, both can report the labor management code. As of right now, the guidelines are stating CNM straightforward, physician complex. However, there's still discussion. There was a lot of discussion about that in a couple of different meetings I was in. So that it should be decided by July 1st, hopefully. Document the handoff explicitly with time and reason for the handoff, and the face-to-face requirement applies. And then delivery and postpartum care, you will report either a vaginal or a VBAC. Third and fourth degree lacerations can be billed separately. Postpartum inpatient is billed with the subsequent hospital E&M codes, and outpatient with the outpatient E&M codes. For billing staff, some key takeaways. Audit your current patients by their estimated due date to determine applicable coding phase. Update your payer contract language. Confirm that E&M codes are accepted for prenatal visits without limitations. I've seen some Medicaid contracts where they limit the number of prenatal visits. Confirm payers are not requiring prior authorizations for maternity codes. They shouldn't be. Check if the payer requires a modifier TH for pregnancy-related E&M visits. Before January 1, you'll want to update your charge capture systems for the new code families. Configure claim edits, which your practice management software should do that. I received an update from ours today that they are already working on it. Build a denial playbook with the top new edits, documentation fixes, and appeal language. Conduct a shadow billing analysis using 2026 cases under 2027 rules, and train your billing staff on labor management, daily reporting logic, and prohibited code combos. And then ongoing throughout 2027, your billing staff and practice managers should be monitoring denial patterns and updating edits quarterly. Watch for downcoding. If a payer changes your 99214 to a 213 without reason, that claim needs contested. Verify each claim is subject to timely filing rules. Do not hold claims. Send them out the door. And reconcile billing across multiple providers for the same patient episode. And then some talking points for talking to the payers for your billing staff or practice management. E&M code access. Payers should not require prior authorization for the maternity care codes. Global codes have not required prior auth, and that should continue with the new coding. The TH modifier should be on the maternity codes. We talked about down coding. Claims should be processed with the same timely filing rules. However, with that being said, I would not be surprised if some of the payers do not extend timely filing like they did when we switched from ICD-9 to ICD-10. Because if any of you remember that, it was not fun. Payments were delayed because the payers did not get their systems in place in time, and claim processing was delayed, so they extended timely filing rules. And then cost sharing. 93% of commercial plan members are in ACA compliant plans. That means 93% of the plans do not have co-insurance, co-pays, or deductibles for prenatal visits and screenings. The only cost sharing they should have is on the delivery itself. Documentation. I cannot stress this enough. Documentation drives your E&M level and labor complexity and directly impacts your reimbursement. Every antepartum and postpartum note needs to be documented with the date of service and gestational age, the problems addressed, including pregnancy status, routine versus complicated, the data reviewed, labs, ultrasounds, records from other providers, the level of risk, so management decisions, prescription drug management, undiagnosed issues, and time if using time-based billing. Your labor management note, each day of labor management, the note should include the date and status, so labor onset or induction start date, initial versus subsequent day rationale, note if it's a new admission, a transfer, or an escalation, straightforward versus complex rationale, and be very explicit. For example, previous C-section, they're automatically complex. Key interventions such as induction agents, monitoring changes, etc., and face-to-face encounter documented. And then your delivery and postpartum notes. So the determination point when labor completed or the C-section decision was made, delivery type and any complications, any separately reportable procedures, 3rd and 4th degree repairs, uterine tamponade, etc. Document all that clearly. Same day postpartum care is included in delivery. And then inpatient postpartum and is noted with subsequent hospital care documentation. Some examples. Patient is admitted at 9 a.m. in labor. It's straightforward throughout. A vaginal delivery same day with a 3rd degree laceration. You can code the 59080 for straightforward labor management, 59431 for a vaginal delivery, and 59433 for the 3rd degree repair. Complex labor. Patients admitted Tuesday at 9 a.m. in complex labor, their previous C-section. Care spans midnight, delivers Wednesday at 2:50. a.m. You can code the 59081 for complex labor on Tuesday, 59083 for complex subsequent labor on Wednesday, the 59432 for the VBAC. A planned repeat C-section with no labor, that's the simplest one. It's a 59503. The docs can't code anything else. And then a CNM, you transfer the patient to a physician, you escalate it. You will code the 59080 for the straightforward if you were first to manage the admission. The physician will code the 59081 for the escalation, the complex labor management. And then if they deliver, they will code that. A quick reference guide to the new CPT codes. I won't go over them again, but this is just all broken out into one sheet for you. The resources. And then coming up next, we will do a webinar on labor management and delivery and a webinar on postpartum and other procedures. I will also be presenting on this at the ACNM annual meeting and attending ACOG's Payment and Practice Conference in New Orleans in November. And the Payment and Practice Conference is all about scenarios and how to bill for all the different scenarios. And if you would like any individualized training for yourself or your practice, please reach out and we can discuss a quote or what that would look like. And I know we're at 7:55, but I have time for questions if Ginger has time for questions since she has the Zoom.
Yeah, we have time. I think if you want to stop sharing, Arden, Denise and I can go from the questions in the chat board from the top down. And then if anybody has any, we can get to, yes, you will have access to the slides. We're going to put them up on the YouTube channel for Grow Midwives. If you want a hard copy, email Arden. That might be the best way to do that. Would planning for induction of labor count as moderate under risk?
Prenatal or when you're, yeah, that would be prenatal. I think it would depend on the diagnosis code as to why you're planning for the induction of labor.
So it depends.
It always depends.
Okay.
It's my favorite. I'm going to hashtag it depends on everything I do.
We'll have it in Kansas City on a t-shirt.
There we go. I'm going to wear it at when I present in Kansas City. Hashtag it depends.
What will be the best strategy for billing group prenatal care? In my previous practice, we used 99215 by time and document preventive care counseling.
So group prenatal care has not been covered in any of the scenarios. So I don't know what the advice is going to be from AMA and ACOG yet on group prenatal care, because everything is moving to individualized prenatal, one-on-one prenatal visits based on medical decision-making and complexity, which from what I'm hearing phases out group prenatal care.
Which doesn't make a lot of sense. You think they're going to have to figure it out because they adopted to teach that in OB curriculum. So I would say stay tuned on that one, but
I agree. It does not make a lot of sense. I don't know. Yeah. I don't think that they will be able to do that. Yeah. So, but that is a great question that I am going to send to both of those groups.
Great.
And I stay tuned. I will have an answer.
Nikki,
not tonight, but I will have an answer.
I think, Nikki, you're talking about antepartum. What about a poor obstetric history or history of preterm birth, preterm delivery?
So both of those are OBCodes. So this is an easy way to describe what will move something to moderate complexity or a 99214 in prenatal care? If there is no condition at all that you can code except for routine, it's just a routine, very straightforward prenatal visit where the only diagnosis code you can code is the Z34 for routine prenatal care, that's a 99213. Unless you're coding based on time. But you still may not have enough documentation to support additional time. But if there is anything in that visit that warrants an O code, poor obstetric history, sorry, I can't talk, is a risk factor. That's an O code. There's a diagnosis code for that. That moves you to a 99214.
Okay. Should we omit the Z34 code entirely or still include it but not rely on it for our medical decision making?
So if you're coding with it, if you're reporting an O code, you cannot report the Z34 code. The O code cancels out the Z34. And if you were to drop that code, you're not your own biller, your biller should be removing the Z34 code and only putting the O code on the claim.
Okay, this one is maybe a little complex, but I'm not sure. Previously, I had been told that triage visits resulting in early labor discharge were bundled into the delivery billing if admitted in the next 24 or maybe 72 hours. Now, would the patient be billed for hospital-based outpatient triage visit and then initial day labor management on the same day if discharged and then admitted labor that same day?
Okay, I think I understand the question. And if I didn't get it all, whoever asked the question, please
Ellie. Yeah,
unmute. And who asked it?
Ellie.
Okay. So, yes, previously triage visits were included in global maternity care if the patient delivered within a 24-hour period, not a calendar day, but a 24-hour period, the triage, or if the patient was admitted. So if they were in triage and then admitted to inpatient, the triage is not billable. Now, if you triage them and send them home, the triage visit is billable no matter when they come back. If they come back that same day, if they come back tomorrow and deliver tomorrow, the triage visit is billable.
That's good.
Yes.
Two people, same question. Is there a code for first assist at C-section?
Not yet.
Okay. Do we need to add a separate code if we complete a procedure postpartum, like an Nexplanon insertion, while still on the intrapartum floor, but they're postpartum?
So it's funny because this was asked in one of the ACOG webinars, and every single person in that webinar said the same thing as I'm going to say, I don't know. Because that has nothing except for what was in the slides tonight, nothing else has been released yet on labor management, delivery, and postpartum.
Okay.
So none of the examples have been released.
Stay tuned.
I will say, I'll just add, this is Elle again. Thanks for answering my triage question earlier. I know currently, like we drop I dropped the procedure code for Nexplanon insertion for inpatient billing when we place them postpartum. So I would anticipate that would be the same.
I would anticipate it be the same also. I bill for them quite frequently. I just don't know how it will change. Like I'm not saying we won't be able to bill for them going forward. I'm just not sure if they're going to have the same modifiers or if they're going to require anything different. But the code for the Nexplanon insertion will stay the same.
Okay, this reminds me of split fee billing. If delivery care starts when the fetal head is visible at the introitus, who bills for the delivery if a CNM consults an OB for a vacuum? Does the CNM still bill for delivery and the OB then bills the vacuum assisted delivery as a procedure?
There are only 4 codes, right? 4 codes for delivery now. So either you or the OB is going to bill for the vaginal delivery. Which one of you that is will depend upon your particular practice.
I think this is more a statement. Again, this is from L. I sure hope they accept complex labor management codes from midwives. We manage high risk patients with OBs in house and should be able to bill appropriately.
I agree with you.
And I don't think they were arguing against that.
ACOG wasn't.
No.
ACOG was 100% for midwives managing complex labor.
Right. Can you bill a
And
triage E&M code as the provider who does the evaluation and then an initial labor management code once admitted?
if it's on the same day, and if you see them in triage and you admit them, it's only labor management if they're not discharged home in between.
Okay.
And going back to managing complex labor, I was going to say something about that when I was talking about ACOG and their support of midwifery codes, but I just lost it. If I think of it again, I'll raise my own hand
Okay.
so I don't forget.
I think I know how you're going to answer this one. We've been told that in a shared or collaborative practice that the MD is reimbursed better than CNM for the same procedure, like in SVD. Is this true or very dependent on state and payer? And will this change with the new billing and coding?
It's dependent on your state and your payer contracts.
Yeah.
In some states, CNMs are paid 100% of the physician fee schedule across all payer types. Some states, it says that CNMs are to be paid at 100% of the physician fee schedule, but Aetna pays you at 85%. Aetna pays you at 85% in like every state except one. So it really depends on your contract and your state.
I love this question. Somebody understands the importance of RVUs, even if we don't like them. Do we have any information on RVUs assigned to each procedure?
Yes and no. So in the work group, the RVUs, the proposed RVUs were talked about in the work group. There are some webinars out there that have listed the proposed RVUs. I cannot list them until they are released because when I was in the work group, I signed an NDA. So I can't release anything until it is released. What I can tell you is I took the proposed RVUs for just an NSVD and I followed it. If you did 13 prenatals, labor management, the delivery, and four postpartum visits compared to the RVUs for global maternity care, and you would have received I think it was 2 more RVUs under the new coding. But it's really going to depend on each pregnancy is going to be different. And so it's going to depend on what you do during the pregnancy. The other thing I can say about that is when you have a code change and the AMA owns the CPT codes, which is why they have a copyright on the presentation also, is because the CPT codes are copyrighted by the AMA. So the AMA owns the codes. CMS sets the pricing for the codes with some input from the AMA. But when the AMA went to CMS and they proposed this code change, They had to propose that it would be a wash. That the RVUs, theoretically, the RVUs and the reimbursement would be a wash. It would be the same across the board if it was global or if it was billed per visit. And that's how the complexity came in. Because then ACOG met with the AMA and they're like, well, what about complex cases? What about this? So that's where the complexity came in. And that's why there's a heavier emphasis on medical decision making versus total time.
Follow the money, huh?
It's all about the money, follow the money.
Will midwife managing high risk or complex cases ever bill critical care time?
I don't know that.
Okay.
TBD.
Did they add any codes for hydrotherapy in labor or water birth?
No, water birth has never been billable. It's a vaginal delivery, whether it's in a tub, in a bed, in the shower, on the floor, in a car, on an exam room table. A vaginal delivery is a vaginal delivery. Hydrotherapy used to pay a long time ago, but hydrotherapy has never been billable for labor. A lot of people have argued that point with me, but in all the years training I've done, the definition of hydrotherapy is for physical therapy, not for labor. If someone is laboring in a tub and has a baby, whether it's in the tub, in a bed, on the floor, does not matter. That is not physical therapy. That is labor. And hydrotherapy is not billable.
So we have some work to do if you want to change.
We have a lot of work to do.
Jody, I think she did answer this, but I'll let her repeat it. Can we bill for hospital postpartum visits, or are they included in the delivery? I missed that.
Postpartum care on the day of delivery is included in the delivery. Subsequent days are billed under the hospital codes.
Is the TH modifier used for both prenatal and postpartum visits?
As of right now, it's for prenatal visits, but I have a feeling it's going to be for both.
Okay.
They haven't addressed the postpartum yet because they're really all the main emphasis, the heavy focus is on what you need to know right now to start billing the new codes today.
That makes sense. I'm out of network in home birth. All my prenatals are an hour long. If I can't medically justify our prenatals based on medical necessity, will my clients have any luck getting reimbursed for my prenatal visits?
So patients who self-submit have a higher percentage of reimbursement from out-of-network providers than if the provider submits on behalf of the patient.
If you have any other condition in pregnancy, is it better to code the whole pregnancy as high risk? So if someone has obesity complicating pregnancy, they should be moved to a high risk code.
So if we're just talking about medical decision making and it's obesity complicating pregnancy, that's just moving you to another level of service. So it's just moving you from like a 213 to a 214, for example. It's not necessarily saying you are high risk at the time you deliver, because if you have a beautiful labor and delivery, that obesity code is not billed for the delivery because it resolved itself during labor. Yes, you're still obese. I'm not discounting that, but the delivery that's billed is a normal vaginal delivery.
Okay. Are the new codes also pertaining to submitting labs?
The new CPT codes because labs are submitted with a diagnosis code.
Okay. Will any mental health screening codes bump the visit from 99213 to 99214 by medical decision making?
Are you using a screening or like, for example, EPDS screen and you're scoring it? Then yes.
Okay.
Good to know. Thank you.
That was Jamie. I gotcha. I don't know what you mean, Jody. Using what code for triage? I don't know the context of the question. Jody, do you want to ask it?
Are you asking what the hospital triage code is?
I don't know.
I think what she's saying is if she sees a patient in triage, how does she code that to insurance? Let's say that patient calls you on the phone on Saturday and says, listen, my baby is not moving. And you say, hey, go to triage. And they're coming from, you manage them in triage and then you send them home because they're reassuring. Then how do you build that to triage? I'm guessing that's what she's asking.
If you're asking the diagnosis code, it's going to depend on why you sent them to triage or why you saw them in triage. Was it fetal heart tones? Was it
No,
rupture of
Arden, no.
membranes?
Arden, I think she's asking for overarching code. It's like she's asking for the equivalent of the CPT code, not the ICD-10.
So the CPT code
triage.
is going to be the OB triage codes, which I don't know off the
Hi,
top of my head.
guys.
Oh, there you go.
Sorry,
I
it's
think
me. I couldn't get on. I'm sorry. Yes, that's what I mean for labor assessment, the overall CPT
Okay,
code for triage assessment for labor.
so it's going to depend on if you're triaging in the ED, then it's the ED code, so 99281 through 285. Or are you triaging
In a
like, is
birth
it
center? In a
if
birth
you're
center?
triaging in a birth center, then it's an office visit code. So
Okay.
99214 215.
Lovely. Thank you.
You're welcome.
Oh, Kat, yeah, I can't believe you asked this. When and how would a billing practice negotiate rates with a bazillion insurance companies?
Well, Katya, the insurance companies are not letting us negotiate rates right now. They told us we have to wait until after July, after pricing is released in July. Then they'll probably push us till January, but I think we're going to have to wait to negotiate rates until after they release the fee schedules.
Oh my God, just
'Cause
shoot me now. Got it.
Hey, Marie, I'm glad to see you here, a new birth center owner. How does this change, if any, for birth center providers?
Well, birth center providers are going to be held to the same rules as everyone else as far as you have to code per visit. The global codes go out the door January 1st. They're gone. And I'm sorry if you hear banging. I'm in my husband's office and the people next door are pounding on the wall.
We can't hear.
Okay, good. So all of the like the maternity code changes that we talked about tonight are not dependent upon they're not dependent upon where you practice. They are everywhere. If you are a home birth provider, a birth center, hospital based, you're only doing prenatal care in an OB office, you're only doing prenatal care for a hospitalist group, whatever the case may be, these are the codes. Global is no more.
And stay tuned for everything else. This is a great question. Will using complex codes set midwives up for liability issues? Will the codes that indicate something as high risk, but within the scope of our care, be used against us by state boards? I would say plaintiff attorneys. But yeah, what do you think?
I don't know.
Yeah, I have some opinions about that. I think as long as your documentation is clear, that is your best defense. Just
I agree.
the terminology of a code is not sufficient. It should not be sufficient enough. but
And
who knows? Because state boards are doing horrible things to midwives right now. So
I agree with that too.
I don't know.
And I think that's why there is so much emphasis on coding based on medical decision making instead of time, because there is going to be a greater chance for chart audits by the payers. There's going to be a greater chance for under and overpayments. There is going to be a greater chance for the OBs are scared of more increased malpractice suits because of deliveries becoming more complex. So your documentation has to be tight. And I'm going to go back to the prenatal flow sheet has a great purpose, but that can no longer be your only form of documentation. And the other thing too that I meant to talk about earlier and I forgot was your documentation cannot be exactly the same for every single prenatal patient you see. Your documentation needs to be dependent upon that person, their specific conditions on that day. And you may diagnose them with something today that when they come and see you next month is no longer relevant. Or you may not diagnose them on something today, and next month they have a complexity.
All right, let's go downstairs, Peggy.
So we have 18 more questions, I think, Arden,
Come on,
and
Peggy.
it's let's at least go to 8:30, and we'll
Come on,
see how
Peggy.
far we get. What about the current trend for hospitals that have OB-EDs versus OB triage units? If a patient is seen in an OB-ED, then admitted, can there be a separate OB-ED charge and then a charge for initial day of labor? I think Winnie Palmer is a great example in Florida. It's a massive hospital that has two huge units that are OB-ED.
Well, it's going to depend on if you're the same group. So if Katya, I'm just using you all night tonight as my example. So Katya sees them in triage and then they need admitted, but she admits to a physician because of what she assessed in triage that's a different group. Then the physician's going to report the labor management and Katya is going to report the triage. But if Katya sees them in triage and then admits them under herself, she's only going to report the labor management for that day.
Okay.
Sounds good.
Hi, Lastasia. She put in the chat board the RVUs proposed at the February meeting by the AMA. I think it's important we know we should stay tuned on that one. There's some bickering going on. Did they say on the AMA webinar TH will be the modifier for postpartum visits as well? I think you answered that.
I do want to address something though about that I meant to earlier. This came up in a Q&A in one of the different trainings I was in. Let's say you see someone for an OB visit, and while you are seeing them for the OB visit, you also treat them for bronchitis. Under,
Yes, you are.
can everybody please make sure they're muted?
Yeah, it's okay.
Under the new guidelines, you can report your OB visit, document that. That is billed, let's say, with a 99214 and the TH modifier. And then the time you spent assessing and treating them for, say, bronchitis, that can be billed on time spent. And so let's say that's a 99213. You would bill that as well. So the 99214 TH for the maternity and the 99213 with a 25 modifier for treating the bronchitis.
Wow.
Can you clarify, is that only billable based on time, or could you bill the
No,
bronchitis based on MDM as well?
you could bill that based on MDM as well.
Okay.
You can bill anything based on MDM, but for anything non-maternity related, the AMA and CMS and all the payers prefer time. Maternity, they're going to prefer MDM.
There's some positive comments, which I think we hope for, that people have listed. I'll go to the questions. Hi, Michelle. Care at home in a planned home birth practice counts as a home visit or an office visit?
Home visit.
Can I ask a question, Michelle, on your behalf?
Of course.
Because
Of course.
I've been to your office, and it's an office, but it's in your home.
Right, but it's my home, it's not the client's home.
Correct.
My
So that means
understanding-
Michelle has an office.
I have an office, so if I'm seeing, my understanding is if I'm seeing them in my office, which is in my home, I bill as an office visit. But if I'm seeing them in the client's home, even if it was
Okay.
planned to be there, that it's billed as a home visit.
Okay.
You are correct.
She has a great
Yay!
office. She has a great office in her home, by the way.
Thank you.
Shamika, so I recall you saying that we don't have to hold codes anymore. How does this work for those patients who are seeking reimbursement?
Can you repeat that? I'm sorry, I didn't catch the.
Maybe, Shamika, it's better if you ask Arden.
So I think someone else asked it above, like for some of us that don't take insurance and we're self-pay and we provide the super bill, and you said we don't hold the codes anymore. How does that work for those clients that traditionally we would just give the super bill and they would seek reimbursement?
So you'll still give them a super bill to seek reimbursement, but the super bill that you will give them will be the individual prenatal visits. So like data service 611-2026 99214 and the appropriate diagnosis codes. It's going to make it more difficult for cash or out of network or cash pay practices that are giving a super bill. It's going to make it more difficult for you to give a super bill to your client. It may be that you give a receipt and see if they can use their HSA or FSA instead of their traditional insurance.
Okay, so just to follow up on that, like circling back. So in terms of the quote unquote super bill, would we essentially be able to utilize that if we essentially gave the super bill at each visit, like give them the invoice that
Yes.
codes for that visit that same day and they submit it? Do you just submit as each appointment occurs instead of like how we traditionally would hold it before?
Yep, they would submit as each appointment occurs instead of global at the end.
Okay,
Because the global codes are going away for everybody January 1st. They're gone. So if they submit the global code to the payer, they will not get any reimbursement.
okay, thank you.
You're
Can I
welcome.
chime in? I was the one who also asked that question above. So can we give them a super bill at the end still that just has the individual dates of service? Or are we required to increase that, because it's going to be maybe 8 or 9 months old by that point. But the burden, like the administrative burden on these types of practices that don't have billers that are generating these bills, are we able to still just after everything's over, give them the super bill, but break it out the way the coding is required? Or are we going to have to give it each visit as they go along? Because timely billing isn't usually as strict for out of network. So kind of trying to navigate what would be required as far as generating those, how frequently we would have to do it.
So timely filing for out of network is typically 365 days from the date of service. And so giving the super bill at the end of care may work. I honestly, none of us know for sure how anything is going to work in January, but you still should be able to do that as long as you're within 365 days of the date of service. The not holding the billing more applies to in-network providers, in-network clinics, in-network, anybody who's in-network. Because as of right now, timely filing varies on contracted plans. Some Medicaid plans I've seen, most Medicaid are a year, 365 days, but there are some Medicaid plans that are 30 days from the date of service. It's crazy. So that's why I say don't hold any billing. Your practice should not hold any billing. It's very important that you chart timely. The other thing with timely charting, now that you're moving to per visit, is Medicare's requirement for timely charting is 48 hours. Now, I personally don't know any doctor alive that charts in 48 hours. The payers don't hold you to 48-hour charting, but you will need to chart timely because until you chart it and sign your chart, it's not a billable service.
I hope I don't embarrass you, Shamika, but she was a student assistant for us way back when, and as a new grad is out there doing home birth, and I'm so proud of you, Shamika. Go girl.
Thank you, Ginger. I'm not embarrassed at all. There goes the baby screaming in the background.
Do we know when the fee schedule will be released?
They're saying July 1st. So AMA is saying July 1st for the RVUs and the fees. When I was looking today on CMS, they're saying September. So sometime between now and September.
Okay. Well,
Can I butt in and ask another home birth center question regarding if we do, like now we do global billing for self-pay for a set fee, and then people may or may not submit that to their insurers or healthcare sharing plans. So if we're not doing global billing, then we're charging per visit. So in terms of what we tell our clients financially to expect, we kind of have to come up with a whole new fee schedule. Is that correct?
That is correct because they will not be able to submit a global code for reimbursement. So it means your financial agreement with your self-pay patients will change. Now, with that being said, if you are billing insurance in addition to being self-pay, to be compliant, your fee schedule should be the same.
Thank you.
Well, we want to thank all of you for being here. Lots of good comments in the chat board. I agree, Katie. We've got Nikki on here. We've got a lot of ACNM leaders. We need you to be a part of the answer. And so I'm going to pitch for us to be an ACNM supporter with your money, with your time, with your commitment, with your advocacy. That is what represents us in critical conversations. So thank you for being here. We will follow up with you on the YouTube channel, the release of the PowerPoint, the charts that Arden's created, when the next webinar will come out. And we appreciate you being here with us. Thanks so much.
Thank you, everyone.
Thank you, everyone. You're tremendous. So